We'll just wait for you all to take your seats and then we'll get underway. So my name's Trish Brad. I'm the Director of Patient Safety at the New South Wales Clinical Excellence Commission, and we're a partner of the BMJ conference this year, and I'm absolutely delighted to welcome you here to the Sunday session. Now, noting that tomorrow we'll see the formal welcome to country, I'd like to begin our session today with an acknowledgement to country. Today at the International Convention Centre in Sydney, we're meeting on the land of the Gadigal clan of the Eora Nation. In the spirit of reconciliation and as a demonstration of respect for the traditional laws, customs, culture and country of the First Peoples of this land, the International Convention Centre Sydney, as well as the International Forum, warmly acknowledges the traditional custodians of Gadigal country and demonstrates respect to elders past, present and emerging. We also acknowledge any Aboriginal or Torres Strait Islander people who may be with us here today. So welcome everybody. Welcome to delegates joining us from across Australia, and an especially warm welcome to those who've travelled from overseas to be with us here in beautiful Sydney. We are really excited to be bringing you all together for the International Forum on Quality and Safety in Healthcare, and are delighted to welcome so many of you here in person and also online. The theme of this year's event is New Horizons, Quality Improvement Shaping the Future. The conference will be an opportunity for you to share expertise and inspiration to create meaningful change, strengthen communities and create confidence in practices and organisations across the region. A lot has changed. It's been a difficult couple of years, but we're excited to be looking to the future. Before we move to the first keynote of the day, I'll just run through some housekeeping for you. We're not expecting any fire alarms, but if you do hear the fire alarm, please make your way to the nearest exit. We ask that you please keep your phones turned off during all the sessions just to avoid distractions. And you may have seen already before you came in, there are toilets located outside of the room and on all levels they're signposted. Clearly, we're also mindful of the current situation in terms of COVID, a situation that is constantly evolving. So in order to maintain the safety of each other, exhibitors and staff, we ask that you please adhere to the following safeguards that we've put in place for the conference. We strongly recommend the wearing of face coverings during the course of the event, except when you're eating and drinking. And you'll see that there are hand sanitising stations available throughout the venue. We ask that you please make use of those facilities where you can. We ask that you're mindful of others and adhere to social distancing where you can when moving around the event. And we request that participants avoid physical contact, such as handshakes or embraces. And if at any point you feel unwell or have any COVID symptoms, we ask that you leave the venue and follow the government guidance to self-isolate and to take a COVID test. But on that note, I'd like to say how very excited I am, and I'm sure we all are, to be back for a long overdue opportunity to bring together the amazing quality improvement community. Over the next 3 days, we'll be hosting discussions and informative sessions delivered by the most inspirational experts in quality improvement and patient safety. The event has been many years in the planning and is an acknowledgement of the tenacity and commitment from event organisers, the BMJ and the Institute for Healthcare Improvement, as well as a committed conference planning committee. It was always our intent to host an in-person conference in the wonderful city of Sydney, and today has put on a beautiful day. Obviously those plans were disrupted, as have so many other plans due to COVID-19, and we're still facing that challenge today. However, today and over the next few days, I invite you to put aside all of that and in a COVID-safe way, immerse yourself in the teachings, sharings, networking, learning, and all the other opportunities that will present themselves to you over the coming days. But now it's time to move on to the main business of why we're here, our keynote session. As you can see in the program, there are a number of esteemed keynote speakers that will be presenting at the conference, and I'm in the fortunate position to be able to introduce two of the best of these speakers. I'm delighted to introduce Helen Bevan, the Chief Transformation Officer at the National Health Service in the UK, Horizons, and Göran Henriks, Chief Executive of Learning and Innovation at Keynote. Helen is acknowledged globally for her expertise and energy for large-scale change in health and care. During her 25 years as change leader in the English NHS, Helen has been at the forefront of many improvement initiatives that have made a real difference for thousands of patients and for the staff who care for them. Göran has been Chief Executive of Learning and Innovation at the Keynote in the County Council of Jönköping, Sweden since 1997. Keynote is a centre for quality, leadership and management development for the employees in the county and also for healthcare on a regional and national level. In their keynote today, Helen and Göran will identify the thinking that's needed to navigate the complex situations that we face today to create a different system for tomorrow. Please join me in welcoming them both to the stage. Thank you.
Helen, it's fantastic to be in Australia.
Yeah.
Thank you very much for having us here, and I'm so happy to do something together with you. I think you are, most of all, a fantastic friend, but you are a living university of creating tomorrow today.
Wow.
And with your social media approach, you are a leader for all of us to find colleagues all over the world that have seen things that maybe we as a person haven't seen before, but through your networks, everybody have a chance to be a part of tomorrow. So it's so fun to work with you.
Yeah. Oh, Göran, that's lovely. Thank you so much. And I'm really happy to be here in Sydney with you as well. And you know, Göran, I mean, I get to work with a lot of people in my own system and around the world. And I think of all the people I work with, you push my thinking the most. And you know, things that you think today, like the rest of the world will catch up with in 20 years' time. And, and you know, I think, you know, to have the opportunity to make this presentation with you today has been tremendous learning for me as well. So yeah, I thank you for being here with me. So yeah, let's get going.
Yes, let's get going. And our idea is that we think it is possible to be in tomorrow already today, but then you need to change maybe part of your mindset of how you think about what you are doing. And with Helen, I started to talk about this to 2013 or something like that.
Yeah.
And we said, let's write a manifesto about how can we deliver the same care with 50% less of our resources. And we started to collaborate. What do we need to make that happen? And we are still on that journey, but we are so convinced that the status quo has to be challenged.
Yeah. Absolutely. And in our session here today, our starting point is no time to stop. And you know, I think for all of us, wherever we are in the world, in the health and care system, these are such difficult times. You know, people are very tired. There's so many demands on the system. And yet we cannot create a different tomorrow unless we make the time to stop and think about things in different ways. So, do you know, the great thing about these 3 days of the International Forum is we're going to stop time. You know, we are over, certainly in the next 60 minutes and over the next 3 days, it's an opportunity, a fantastic opportunity to stop. So we're going to start with a poem. So, this is an an extract from a poem by Paul Anthony, No Time to Stop. No time to stop, no time to waste, no time for anything but haste.
No time to wonder at the snow, no time to watch our children grow.
But time enough to rush, 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 and time enough to push, push, push.
But no time to care or to smile, no time to ramble for a while.
No time to sit, no time to stand, no time to shake you by the hand.
No time to stop, no time to blink, but most of all, no time to think.
And Göran, why do we need to stop? Why do we need time to think?
Well, I think that in the daily life, we are so focused on what we try to achieve for that day. And we are kind of stuck in a production system with old ideas of what makes efficiency and good results. And I also think that sometimes we are quite linear in our approaches, and that reduce the chance to find those spots of time that we need to reflect around what's happening next. So Helen.
Yeah, so just a little bit about the objectives of this session. And yeah, we're going to stop time. We've taken the hands away from the clock. And what we want to do is we want to identify some of the big dilemmas and challenges in creating tomorrow today. We want to think in some different ways. So we want to reframe the questions we're asking about making change happen, and doing that with different thinking from a different mindset and perspective. And we want to see the big picture and search for new possibilities. So let's get going and maybe think about how we might do that with each other. So we are going to do a hand vote, okay? And we want everyone to join in, and you have one of 4 choices. So in terms of where you're sat at the moment, okay, if you just know the person to the left of you, will you put your hand up? Ooh, about 10%. Okay. If you just know the person to the right of you, will you put your hand up? Well, there's more, definitely no more on the right, that's good. If you know the people at both sides of you, put your hand up. Okay. And then finally, if you know neither of the people at the side of you, or you're sat on your own. Okay, actually that's about 30%. So, just give you a couple of minutes. What we want you to do is to say hello to those people that you don't know. And in terms of this dilemma that we're talking about, in terms of delivering, balancing, delivering what we have to deliver today and doing things differently for tomorrow, okay? How are you doing that? So say hello to the people that you don't know. Over to you.
It was a good introduction.
Yeah, it's really good. This says you can't be interactive now.
So we're on 53 or...
give you 1 more minute?
No, stop.
No.
Yeah.
Okay then. Hi everybody, we're going to come back together now, if that's okay. Like Göran said, you know, many of the answers to what we need to do to create a different tomorrow are already there today, and I just think there were some very good, helpful conversations going on there. So, Göran, you're going to talk about the challenge in numbers.
So I have a big interest in different kind of sports, and there we talk about efficiency and how close to the goal you can come with the ball before you try to make a goal. And when I look at these figures that comes from England, and they are similar to the Swedish figures, I get worried, because if you would take some proudness of your own work and see how close you are to the efficiency, the possibility of efficiency, you can get worried when you see these figures. In cardiovascular disease in England, about 15% of the patients do not get all the indicators or procedures in place when needed. And in diabetes, the figures are around 3 out of 10. And when you look at the mental health issues, it's less. It's 4 out of 10. And when you look at osteoarthritis, it's like 65 out of 100 that do not get the right treatment when they should get it. And in Australia, we find research from Braithwaite and his colleagues that says that healthcare represents a paradox. While change is everywhere, performance has flattened. 60% of care on average is in line with evidence or consensus-based guidelines, and 30% is some form of waste of lower value, and 10% is harm. So are there a 60-30-10 situation that is the status quo of how the performance looks like? I think the question should be phrased.
Yeah, and you know, we looked at English data and a wise Australian commentary, and actually we see the same thing that's coming from the USA. This is a quote from the findings of the National Quality Task Force in the USA from 2020. And again, it says, you know, despite impressive gains in terms of quality, notable shortcomings persist in normalizing consistent, high-value, person-centered care. What is primarily missing is not progress in measurement, but progress in results. Changes in culture, investment, leadership, and even the distribution of power are even more important than measurement alone. And you know, when we put those kind of 3 pieces of evidence together, what it's telling us is that, you know, our current approach to quality improvement, we're making impressive gains, but there's a very, very big gap between where we are now and where we need to be.
So we cannot continue the way we are doing as a system. And I think that John Maynard Keynes' notion that the biggest challenge is not to make people accept new ideas, is to make them abandon the old ones. The older I get, the more important I think this is. And together with Maureen Bisigiano, we were trying to explore the word exnovation 2-3 years ago. And in other industries, exnovation is a big concept, because you have to exnovate before you innovate. You have to take out before you put in. But we have a habit that we just put in. And how do we take out things before we bring in things? So exnovation, innovation, learn, unlearn are key issues. And I think the most radical thing we can do is to look into the service models we have. Do we have our citizens as partners, or are they just guests in our processes? Helen.
So what kind of mindset do we need, okay, way of thinking to embark on or carry on with this journey? And this is from a tweet that I sent recently. Actually, you know, making the time to stop and you know, making the space to create a different future today. Another way I'd maybe think about it is having the space to shift from being an expert to an explorer. You know, when you work in quality improvement, it's great being the expert, you know, because you know a lot about improvement, and lots of people come to see you, and you know they want your wisdom, and you become this kind of person that's the go-to person that has got a lot of knowledge and you know tells people what they can do and gives them advice, and that's great. Okay, the problem with being an expert is that it gives you a closed mind. You know, and what happens is that when you become an expert, and very often it's other people that put you in the box of being an expert, you shift from learning to knowing. And the problem with knowing is that we don't know enough in terms of the kind of future that we want tomorrow. But when we're truly curious, we shift from being an expert to being an explorer, supporting others on their journey. So, you know, in these 3 days of the International Forum, okay, let's all be explorers. Now, you know, thinking about this, what strikes me, there is a very fundamental question that I think we're curious about. What if, when we've actually got the time to stop and think about it, in our improvement journey, are we in the wrong paradigm? Okay. Now, this comes from Donella Meadows. Donella Meadows is a system thinker. She's one of my all-time heroines. And what she says is that if we're thinking about how we're going to create change in the world, okay, we need to think about leverage points, or if you're British, leverage points. And here, okay, we have the system, and we want to improve and change the system. And we've got the fulcrum here, and these are the various leverage points, you know, interventions that we can make to change the system. And the ones that are nearest to the fulcrum are the points with the lowest leverage, and the ones that are furthest away are the points with the highest leverage. So let's look at these, okay? You know, where are the places that we should be intervening in the system? Okay, the ones here, if you like, with the lowest leverage, the 3 points there are all about changing the process, okay? Redesigning processes. As we move out, okay, we've got the places to intervene in a system, okay? The leverage points that actually create more leverage than changing the process, but not as much as some of the other ideas. And these are all about, okay, approaches that are about changing the patterns and the flows of information, you know, learning systems, working effectively with data, and changing behaviours. As we move out, okay, to the more effective leverage points, they're about changing the social system, changing the rules of the system, the structure and the goals of the system. And eventually, we come to the points, okay, that are the most impactful, okay, that will make the biggest difference. And these are all about changing the paradigm or the mental model, you know, fundamentally thinking about things in different ways. And unless we make the time to stop and think about things in different ways, okay, we're not going to create a different tomorrow.
So the word paradigm becomes very important if we are up on the further right side of the previous picture. And Thomas Kuhn, a philosopher, talked about this nearly 100 years ago, and he had a picture of a rabbit and a bird, and he tried to illustrate the problem with the paradigms, with the picture that you couldn't see the rabbit and the bird if not you had a bottom in your mind that said, now I see the rabbit, now I see the bird, now I see the rabbit. And we are talking about now, can we find that bottom in our minds so we look at the same things in different ways? But then we have to understand what is a paradigm. That's a set of assumptions, concepts, values, and practices that constitutes a way of viewing reality for the community that shares them. So if we should change the view and how we see things, we need to work with all these things at the same time. Now, that's not so sensational. If you read the investigations that different organizations have done the last 5 years, you can find this request that we need to rethink our paradigm. World Health Organization were writing that we need an intersectoral action for health, equity, and well-being 7 years ago. And it was 4 pillars. How do the healthcare systems view the journey of the citizen's life and not thinking about their own method? And how do the systems empower people? I'm not sure the word empower is the best word, but it means how do we involve co-production and co-design concepts in our processes. They said the only way to do this is to have a people-centered health system with public health capacity, emergency preparedness, surveillance, and response. And for me, that's a mission that says you have to work with the communities in new ways. They talked about tackling the major health challenges of non-communicable and communicable diseases. And for me, that's the health literacy issue that we are now dealing with, especially in all our efforts to now bring in new technology, digital resources. And we see that a part of our communities do not use those. And the gap becomes maybe even bigger. It is the people that have knowledge of this kind of resources that start to use them. And finally, how do we build resilience in the neighborhoods and not in a structure around the neighborhoods? And Helen, it's not only WHO.
Yeah, you know, what strikes me is, you know, when you start to see these kind of major shifts happening in thinking, they come from multiple directions at the same time. And, you know, exactly the same kind of new paradigm thinking is really starting to break through now in the quality improvement world. And what I've got here is just an extract from a new paper that is a work in progress. And it's been written by Peter Lackman, Paul Bertolden, and Chris Van Hagt. And it's all about a new approach to quality. And they call it Quality 3.0. Okay? And what it's about, if you like, is a new paradigm for quality improvement. It's a work in progress. So if any of you want to comment on this, okay, you can actually go online, the link's there, or you know, take a photo of it and just Google it and go and have a look at it. But essentially, what they talk about, okay, is the continual development of thinking and practice with regard to quality improvement. And they start off with quality 1.0. And this is about, you know, thresholds, meeting a minimum standard. And the question here is, how might we establish thresholds of good healthcare services to make sure that everybody achieves the threshold? And the kind of illustrative themes we've got here are the development of quality standards, using inspection to assess whether the standards are being met, certification when the threshold is met, and obviously working through guidelines. And, you know, what we've seen, I think, over the past decade is a shift that's happening from quality 1 to quality 2, and the quality 2.0. And the kind of theme of quality 2.0 is about organisation-wide systems for quality. So the question is, how might we use organisation-wide systems for the best disease management? And the themes here, okay, are different, and they're bigger. So they're about, you know, the systems and processes for delivering high-quality care. They're about how we have reliable, safe services. They're about customer supplier. And we can think about that in terms of customer supplier with regard to internal processes in the system. And we can also think about customer supplier when it comes to the relationship between consumers and people that provide services. And it's about measuring and understanding performance. Okay? And we're now moving to quality 3.0. And the big theme of quality 3.0 is the co-production of health. And the question is, how might we improve the value of the contribution that healthcare service makes to health? Okay? A much more fundamental question. And the themes here, the first one is about the logic of making a service, and I think Göran's going to return to that shortly. Okay? The next one, you know, who owns health? Okay? Does the system own it? Do people own it? The third is about this theme of kinship. They talk about kinship and they talk about kin. Really interesting. Some people like it and some people don't. But what it's about is, you know, very often we're talking about person-centred care. And what they're saying as part of Quality 3.0 is, you know, we need to move beyond this just being about person-centred, and it needs to be about kin. And kin could be family, but actually it's much broader than that when they're talking about kin and kinship. It's about, you know, the responsibility of and the contribution of wider communities as well. They talk about a theme about integrating multiple knowledge systems. So these can be, you know, expert clinical systems, knowledge systems, and best evidence. And they could also be the kind of knowledge systems that people with lived experience, okay, build collectively. You know, the kind of peer-to-peer knowledge systems that make such a difference. And then finally, how do we create a system architecture that truly adds value in a health context? So yeah, it looks to me like the paradigm is shifting.
Helen, before we switch picture, I need to say something about how we learned about Quality 3.0. About 15 years ago, a group from a system in Trento in Italy came to Jönköping and said, do you like to join us in a trip over United States to show how we with our schizophrenia patients, have made a completely new approach to achieve non-hospital care for acute schizophrenia patients. And they convinced us that if you have older schizophrenia patients at the emergency room and they meet the acute patient and say hello to them and their family, they reduce the time at the hospital to a day or two. Then we got self-dialysis patients that taught us that they can do the full dialysis process if they have a good collaboration with nurses and doctors. And then we had patients that have been in motorcycle and car accidents, teaching new patients how to drive a car or how to go to the swimming hall. And we saw that they reduced the time of having the patient doing these things with 50%. We got so convinced. So today we have a lot of employed patients that work as facilitators within our system. And that brought us also to the insight that we have to reframe how we measure our doings. So today we say we have to build a measurement system that shows what kind of life do our people, 365,000 people, have, and what kind of health do they have. Because the notion that every system is perfectly designed for the result it gets also is something that we have to understand. So we started to ask ourselves, what is the next generation of healthcare system that can live up to the vision for a good life in an attractive region? So we invited our 13 municipalities CEOs to a leadership journey for 3 years, and it's going on right now, where we build trust, we build belonging, and we start to define the health issues through the same glasses, the same perspectives. And in focus are the quadruple aim ideas. So it's the health of the population, it is how we use the same resources in a better way, and we look at the taxes as a common income. And we know that our citizens don't want to pay any taxes, so it's our obligation to reduce the use of money as much as we can. And we should do that in collaboration with the municipalities. It is, of course, changing the journey view and the process view, so it's not the work processes, it's the patient's processes, and it's about the well-being and the support of care. One main issue was that we had CEOs of the hospitals, and the CEOs of the hospitals tried to make the hospitals as strong as possible. And the chief of care centers wanted to make their care centers as strong as possible. So we got a tremendous suboptimization. So we said we should take that structure out of our system. Think in macro, meso, and micro system ways, and decide that we shouldn't have any CEOs of that kind. So we have CEOs of horizontal integrated processes today. And we wanted all measures to help them to go from reactive to proactive management, and not only using the patient records, finding new data sources. So on the journey we are, where we try to reduce the influence of the production model, where we have the consumers and families and communities involved. We think that it's so important to develop collaboration with the municipalities, the systems around us. We are just a system among the systems around us. And we have to start to talk much more about our service logic based on co-creation, service processes, and social knowledge. Therefore, today we don't have an organizational chart any longer. We instead map our challenges in 4 components: health in daily life, self-care and how we support that, how we transform primary care to become a resource for also specialty care, and specialty care, how specialty care reduced their own suboptimation and becomes a resource for the whole system. And that brings us completely new system thinking.
Yeah. Do you know, Göran, I think we should stop for a moment and we should just give our audience an opportunity to just reflect on this. So, you know, Göran has been talking here about the system journey in Housekeeping, you know, with regard to our goals for quality improvement. So why don't you just have a couple of minutes now and talk to your new friends, okay? Where are you in your quality improvement journey, okay? So, you know, do turn to the people that you met before. Where are you on your journey? Do share your ideas. I thought we should just do this. Just give people a minute. And then there'll be come back together now, if that's okay. So, you know, Göran said here, we need simple rules to unite people in system thinking. And if you remember back to the definition that Göran made of a paradigm, okay, a paradigm isn't just what like one person thinks. It's about what a group of people think together. And if we are going to fundamentally change the way that we do things, then you know, we need to create some ways to change our thinking together. And working with simple rules, a set of principles that we can all stick with and interpret in our own way, I would say it can be a very powerful way of shifting paradigms. So this is the work that Göran and I have made our joint quest since 2013. So this is about version 50 of our simple rules. In a sense, they're the things that as leaders we should concentrate on or focus on if we want to create tomorrow today. And what we'd like to do in the last part of our presentation is to take you through some of those rules. And we're going to talk first of all about, you know, when we come together as an organisational team or community, we need to start by defining our shared purpose. The second simple rule that we'll talk about is about, you know, our transformation of efforts, wanting to do things differently. We have to root them in a sense of belonging. Göran's going to tell us a little bit about predicting and preventing. So actually starting our thinking about our intervention, okay, you know, where we create the leverage much earlier in the care process. Number 4, we're going to talk about in terms of supporting people to build agency. And by agency, we mean the ability and the power to act to make a difference. Number 5 is about embracing contradictions and tensions and understanding that contradiction and tension is at the heart of change in large complex systems. Number 6 is about unleashing learning as a power for transformation. And then the final one that we're not going to talk about today is about actioning small-scale changes within a large-scale framework. And what we mean by that is, if we want change to happen, the most effective place for change to happen is in community. It's at point of care. Okay? It's about lots of small-scale changes. But often if we work with small-scale changes, then they end up like 1,000 flowers blooming, loads of small changes, and they don't add up to anything big. So we need to think about how we action our small-scale changes within a larger-scale framework that everybody understands and is connected with our shared purpose. So let's get going. Okay, number one is about defining our shared purpose. And all three of those are really important. Okay? We need to think about the our, who are our people, who needs to be part of this change process, who's in our team. We need to think about shared, what are the things that unite us, okay? And then finally, purpose. What are we here for? What are we trying to do? And I just want to show you a particular example of this and our shared purpose statement. And this comes from a fantastic initiative which is called #EndPJ And this is a global movement that actually started in Australasia. And this is about people, frontline people at the, people working at the point of care who, seeing many patients in hospital beds, lying there in pyjamas, becoming very deconditioned, not being mobilised, and wanting to do something about it. And last week, End PJ Paralysis had its 4th global summit. And it doesn't have a formal organisation, it doesn't have money, it just has an amazing band of people all over the world who care passionately about this topic. And it's made a really big difference. So here we've just got a headline from the Nursing Times in the UK, where the campaign to end PJ paralysis saved 710,000 hospital days. Okay? And what underpins it? Why is this going on from strength to strength year after year? I would say because there's a very strong sense of our shared purpose. So let's just think about this. Who are the our? Okay? The our are patients and families, they're nurses, other clinical professionals, care assistants and students. And one of the things I'd say is that when we go to improvement school, we get told or we get taught the very first thing you have to do is to create an aim for improvement. And I think aims are very, very important. We should always have an aim in our improvement work. But actually we have to start earlier. We have to start with who are our people, okay? Who are the our? Because if we want to build community and transform things, then we have to have a situation where all of our people, okay, are part of creating the aim. Next is shared, what unites us. And what unites us here, anger and outrage at older patients deteriorating when actually it's in our power to do something about it, okay? And that anger, okay, moves us to action. And then finally, what's our purpose? Whether we're talking about a team in a particular care setting or we're talking about a global movement of people that care, okay? What our purpose is to make sure that every person in a hospital bed gets mobilised when they're ready, both clinically and professionally, and that every person gets choice and a chance for the future life they want. Because we know that, if we've got people over 80 years old in a hospital bed and we are mobilising them quickly and stopping them becoming deconditioned, it can make the difference between that person going back, leaving hospital and going to the independent life they want versus needing to go into a care home. So think about this, whether you're thinking about your own work team or you're thinking about a transformation project or a community that you're working with. Okay, what is our shared purpose? Number 2, root our transformation efforts in a sense of belonging. When I think about my own practice as an improvement leader, the thing that I am doing most differently to what I was doing 2 years ago is really focusing in on this issue of belonging. Okay? I think any improvement, transformation initiative that we're working on, we need to build really strong foundations of belonging. This is research that Deborah Rowland and Paul Pixovic did. And, this is what they concluded. That basically building a sense of belonging is one of the most critical tasks in leading change. And it's something we need to put a lot of effort and energy in at the beginning of a change process. And they say, our most recent research into the successful leadership of large-scale complex change pinpointed a vital ingredient omnipresent in all human systems, our fundamental need to belong. Okay? If we want people to be part of our shared purpose, to be part of our change journey, we need to build that sense of belonging so that everybody feels secure, psychologically safe, included and part of something significant. And if you feel you belong, loyalty follows, and with that, the permission for risk-taking and innovation, okay? So how do we build belonging? Okay, well, the first thing we do if we are improvement leaders is we create a driver diagram. So what does it take, for people to feel I belong? There's actions that we can take when it comes to the climate, okay, that we create in our organisations and systems and around our improvement work. So, welcoming the unique thing that everybody brings. We want people to feel a sense of belonging, bringing their true self, to the work. We want openness, fairness, and again, we need to focus on the shared part of our shared purpose. Unites us, not what divides us. As a lead, then the second category, if you like, from our primary drivers is about leadership. And it's our job, to give perspective, to create a sense of why we're doing this. It's about mentorship, it's about inclusion, it's about being kind and civil to everybody. And then we need to think about our practices, okay? Listening and giving feedback and taking the time to listen to everybody, understand everybody's background, everybody's story, okay? Building agency, and we're going to come back to that in a moment because it's number 4. Collaboration. And again, this power word, okay? Power with, not power over. Göran, number 3.
Yes, that's about prediction and prevention. And quality improvement in itself is a prediction theory, if we do it the right way. If we have a hypothesis, if we try to take it in small steps, and we try to learn from every step, then we come into a prediction of how well it can become. But I think that COVID, for example, gave us a completely new way of using prediction thinking and prevention together. So in Jönköping, my infection disease doctor saw that there were too many patients that came to the emergency room that immediately had to go to the intensive care. And that was because they came in too late. So they started to see if they could find a theory that made us bring in the patients earlier to the hospital and bringing them from the emergency room to not the intensive care unit, but to a COVID unit that could give them oxygen support for some days and then go home. So we started to collaborate with the statisticians and the primary care doctors and nurses and asked them what they think they could do to reduce the risk for a certain group of patients that the statisticians could find that had a bigger risk to come to the intensive care unit. And what we found was that if we could come in contact with that group of patients and give them an oximeter so they could by themselves measure how well they got oxygen to the blood. And it seems to be patients that had problems to feel how bad they were feeling because the more sick they got, the more they were sitting, and they didn't know how severe ill they were. So we started to give out for free oximeters, and we found that we reduced the group of patients with high risk of COVID at our intensive care unit. And that was a combination of prediction and prevention. And I think that we can use this thinking in so many more patient groups if we get the data right, if we have place for thinking as our intensive care doctors took themselves in this very tough situation. I'm not sure that in our daily production, we should have thought about this in this way. We should have been reactive and continued to do the same way as we always have done.
Okay.
Helen.
Yeah, so let's talk about number 4, which is about supporting people to build their agency. And an agency is about the ability and power to act, to make a difference. And, you know, let's understand that, you know, when we're talking about agency, you know, people taking the power to make a difference, that people have got very different starting points when it comes to the amount of power they've got and how much privilege they've got. And, you know, when we talk about agency, you know, the power and ability to make choices and act on them, there's multiple levels of agency, and we would talk about individual agency. You know, whether we're talking about people that use services, patients, consumers, or we're talking about people that work in our system. But it's about people getting more power and control in their own lives, you know. And we can do this through thinking differently. We talk about self-efficacy, which is about confidence and belief that I can make things happen. Shared decision-making and or self-care. And I'm involved in a project in the National Health Service in England called Solving Together. And we have got an innovation platform where consumers and anybody in the system, okay, who works in the system, can put ideas around how we can, actions that we can take to speed up the recovery of our elective and planned services. And you know, the feedback that we've got from patients and consumers, we've had 100,000 interactions with this innovation channel, is just this issue about power and control and how important it is to people. And you know, very often people don't mind waiting. But what they do mind is a situation where they don't know what's happening. They don't feel they've got any power, any control in the situation. It's so important that we take actions to build agency when people are waiting. And then there's collective agency, which I think is the most powerful kind of agency. And that's where, you know, people are acting together, united by a common purpose, harnessing the power and influence of the group and building mutual trust. And, you know, when we sit down together and we think about our shared purpose, you know, we build collective agency. So, you know, some things we'd say about agency. Actually, you know, so much of what we're talking about here with quality, you know, 3.0 and you know, thinking about the value of healthcare to health. You know, what we'd say is agency is vital to improving the value of the contribution that healthcare services make to health. And I know it's very hard to believe, but between us, Göran and I have got over 70 years active service as internal change agents in our system. And you know, what we would both conclude is when change and improvement efforts fail and they you know, they don't always get their objectives, it's far more likely that they fail because people haven't got agency. Okay? People are change agents, improvement, you know, are leading improvements, and they haven't got the, you know, the power, the permission, you know, to move things forward. They're far more likely to fail because of that than because we haven't got enough improvement skills or we haven't got enough resources or capability or methodology. So, Göran, give us an example.
Yeah, I have a cute story, Helen, from our children prevention work. And it's about a cartoon movie that we have made of a visit for the 4-year and 3-year-old kids coming to this child prevention meeting where they should take their weight, their length, and give them vaccination and so on. So the parents are asked to show the movie, because it's on the web, for the children before they come to the visit. And when they come to the visit, these different cartoons are on a table, and the child himself, in Sweden we say hen, we have a third word, both he, she, and then we have a third word, that's hen, because we are neutral in this kind of approach. So when hen comes, they can then choose what kind of things should be done first. Is it feeling at your stomach, taking your length, looking into your mouth, or is it maybe get your vaccination? And the strange thing is when the child puts up the cartoons on the wall like this, they are not doing it the same way as the nurses decide the process before, because the nurses wanted to take the shot as the last thing of the visit. But the children always decide, we want it first, and then we can do this fun things. Can we do this for all patients? I guess we can.
Yeah. And you know, agency is also a really big issue when it comes to people who work in the system. And this is from a learning review that we did a little while ago. And so many of our colleagues at the point of care, nurses, allied health professionals, doctors in training, support workers, people said, I've got so many ideas about how our services could potentially be improved, but I haven't got the power or I haven't got the permission to make them happen. So, when we think about the future, okay, and the different future that we're trying to create, and we think about the skills that people need, then we should think about competency, okay? So, the quality of being competent, the capacity and skills that we have individually and collectively. And we need to think about agency, okay? The power and ability to make choices and act on them. So often in quality improvement, we see organisations and systems where people are trained, a big investment is made in training people in improvement skills, but they haven't got the agency, so the change doesn't happen. So when we think about the future and the kind of competencies that we need, we love improvement methods, okay? And, we need people to be skilled in methods. We will still need really good project and program management. That isn't going to change, We need to be able to work with innovation and people-centered design methods. We need to work with measurement and analytics and be able to use data for improvement really effectively. And in an increasingly complex and relational world, we need process facilitation skills, influencing skills, and we need coaching skills. But, it isn't enough. When we think about agency, okay, what do we need? Well, we need to think about agency in terms of inner skills. And what we mean by that is who I am and the way I think and how I operate in the world. You see, being somebody that does improvement isn't enough. We have to be the people that be improvement, okay? And the way that we think and all our actions, because what it means when I be improvement, actually I bring a bigger person to the world. And we need to think about the outer skills, which is about in relationship with other people, building collective agency, connecting and collaborating with other people, building that collective agency, that power to make a difference. And if anybody doesn't think this is important, here's some more data from Deborah Rowland. And what her studies showed is that when leaders, people leading change, can cultivate both those inner skills that help me be a bigger person in the world, and those outer skills of connection and collaboration that lead to collective agency, it increases their chance of success in large, complex change by 52%.
Helen, our topic was stop the time, and
Yeah.
I wish we could do
I
that.
know.
But let's take the next one, because time is one of the biggest dilemmas and give us the biggest tension, I think. That we believe that life is a dilemma. And we think more and more that we need to help leaders to live with the dilemmas. I have been invited to so many lectures last years about what do you think about future and healthcare. And they want me to talk just about AI or AR or HR. They want me to focus on one thing at a time. But the future is not that. It's not the silos. It is how we live with the different dilemmas that all the different knowledge platforms gives us. And that brings us to the conclusion that we need to have a patient community-led healthcare much more than what we have today. We also think that personalized care versus standardized care is a dilemma that we need to live with and also develop our understanding on how to combine precision medicine, personalized care with standardized care. And then, of course, there are a lot of dilemmas in all the future knowledge platforms that we have. So, Helen, should we say something about this?
Yeah, should we do this one? Should we talk about this one, I think? Because I think
Yeah.
it's a really good example of attention and contradiction. So, we've been talking a lot about, mindset, okay? Our mindset, the way that we think, our paradigm drives so many things. And what we have here, okay, is, in terms of our organizations and the future that we want to create, we need to have both a compliance mindset and a commitment mindset. And this model here from Gary Hamel is a hierarchy of capabilities. And what it basically says is, the higher you go in the capabilities that people have, the more we maximize the contribution that every person can make. So if you look at the bottom three layers, okay, these are all qualities that as leaders we can expect and command people to do. We need people to be obedient. If there are rules that we have to follow, everybody should follow the rules because they're the rules. And we want people to be diligent, like working hard, to do the work that's expected. And we want a high level of expertise, and we expect people doing a certain role, okay, to have the level of skill and expertise needed for that role. And we can, as leaders, we can expect people to have those capabilities. And if we want to create the kind of tomorrow that we've been talking about in this lecture, then we need people to have the higher level capabilities as well. We need people to be able to take initiative and do things in different ways. We want people to be creative. We want people to find different ways of doing things. And, to do things in different ways, we have to take risks, we have to be daring, and it requires courage. But these top-level capabilities, initiative, creativity, and daring, we cannot command people to do those things. People have got to want to do those things. And again, when we think about the whole experience during the pandemic, what we saw time and time again were people working at the top part of that hierarchy, moving very quickly, trying, experimenting, trying new ways of doing things. So, we need both, okay? Because we cannot have a safe, high-quality health and care system without obedience, diligence, and expertise, okay? And so we have to live with the contradiction of both.
So, if we should encourage this, we need to leave the focus on just a vertical integrated system. I think we need to find our work patterns in a horizontal, multiple, co-integrated system where the language is different. It is a network model, and in this network model, it's about shared purpose, simple rules, collaboration. And that brings us to maybe the last thing today, and that is, how can we unleash learning? Well, learning, in my view, can be different things. Sometimes we ask people to join us. Sometimes we ask people to join in, and sometimes we ask people to join up. When we work with clinical performance based on standardized guidelines and protocols, then we ask people to join us and improve the work processes they already have based on those guidelines. If we are not sure about the connection between cause and effect, then we start collaborations with teams that can do tests in maybe a little different ways, and we see that we can find transformative examples. But if we want to enable a healthier life, then we have to have the patients as members of the same improvement network. And then we can transform the system in the power of who is driving the health issues. And then we have to have a network model. Finally, Helen.
Yeah, so just thinking, about what we've covered in the last hour, just, time to think, okay? Think about those 7 sets of rules and how they might apply to you. So, how can we define our shared purpose? How can we root our transformation efforts in a sense of belonging? How can we build prediction and prevention into everything we're doing? Okay? How can we support people, whether we're talking about communities, patients, consumers, people that work in our system, to build their agency? How can we embrace contradictions and tensions and not try and solve one or the other? How can we unleash learning as a power for transformation? And finally, how can we action our small-scale changes within a large-scale framework? So, what we hope is that maybe some of those have inspired you and given you some ideas and in a sense, challenged your own paradigms. We're running out of time, but we just want to do one thing, just for 1 minute, if that's okay. And we'd love you to have a final neighbour conversation and to say, when you get back to wherever home is, how would you summarise this session for your colleagues or friends at home? So literally 1 minute, how would you summarise? No, we're good, we're good.
You can. Let's go.
Yeah. Okay, and finally, we come back together.
Thank you. Wow, what a session, what a way to start the conference. Fellow explorers, we started our journey of reflection and I think of change, and we were encouraged, as we've just heard, to think about those 7 leadership opportunities that we have, but also to think about how we sit in the bigger, large-scale improvement opportunity of change that we have. What is our paradigm? How are we seeing the world? A fantastic way to position us for the rest of the conference. So I think we've started beautifully. There's lots to think about. personally and I think professionally. And as you go out from here today, please continue the conversations that you've had here this morning. We just want to point out that the next session is starting quite soon at 12:15. There will be an opportunity to grab some refreshments as you go up one level. So the next sessions are in C3, rooms 3, 4 and 5, just up the elevators upstairs. Now, if you're not sure what session you've booked into, just check your emails or have a look at the guides. And lastly, don't forget that we'll be back here today at 4:30 to hear Ashley Bloomfield also share his experience and lead the final keynote for today. So once again, as we finish up, please join me in thanking both Helen and Göran for an amazing session.